you see the slides?
Yep.
All right, let me,
We don't
if I
have a lot of
advance
people.
them,
We don't have a lot of people. Tonight there's only like
no,
170 registered, so it's gonna be a small webinar. But if you want me to share the slides, actually, I don't, for me, it doesn't change anything. The only thing is like, because I have multiple screens, it might like cut off the bottom or something. I don't know what the hell happens. But you let me know.
okay.
You let me know.
What
if you
I
want me to share.
noticed when I go to share my screen, okay, I think we should do, when I go to screen, it says screen or clean. I always click screen because clean cuts off the bottom. I don't know if you get that option, screen and clean screen. I don't know.
I don't know. I can
So I always
try.
choose screen.
I haven't done it in a while.
All
I
right,
don't
hold on, let
remember,
me,
but I can give it a try if you want. I don't mind.
stop.
Doesn't bother me.
Let's see. Stop sharing. All right, so I've given you sharing permission.
Okay, so show my screen. I see here, and I drop down and select screen monitor. Let's say what's it? Screen monitor 1, clean, hide icons, background, and tasks. Right?
Yeah, you don't want to do that. Don't do clean.
Don't do clean.
Clean cuts off the bottom.
Oh,
Don't do
okay.
clean. Clean cuts off the bottom.
Okay, do the other one. All right, so I did that one. Here we go. So now I'm gonna open up this guy. And I'm going to go like this.
That's a cool background.
And I'm going to bring that here. And then I got to do is press the slide thing, right? Normal, slide sorter, no. This one, slideshow.
Next one over, that one. Yep,
That's the one, right?
that is the one.
Okay.
Perfect. That's perfect.
That's another one. I have another screen that pops up too, I guess. Okay, so I'll just put this one on this side. Okay, that's fine.
Oh,
You
now
still see it, right?
yeah. Yes,
Okay,
I still see it.
I'll leave it on like that.
Okay. So
Now,
because at least if I have a choppy intro, it's
yeah,
okay,
I don't
right?
care.
My
For me,
intro's
don't
not
worry about it.
important, but as long
Don't
as
worry
the
about it.
slides are good. So when Dr. Armstrong gets on, we'll test her ability to change the slides. So I'll need for you to give her slide control. So
Okay.
but we'll do that when she gets on.
Yeah, no problem.
Thank you, Nico.
Hey, no worries. I'll just leave that on for now like that. It's
Perfect. That's great. Thank you.
all right. So I'm gonna mute it. Where are you guys at today? In New York?
We're in New York.
Okay. So I thought. All right,
Yeah.
I'm gonna mute myself. If there's anything, I'm here.
Okay, thanks.
Thank you. is the doctor coming on soon, Ashley?
Ooh, no.
Hello, Dr.
Hey, Ashley, how are you?
Doing well. I was just on the phone with Dr. Armstrong. She's restarting
Yeah,
her computer. She was having a little bit of trouble getting in. So
that's fine. How do I look?
you look good.
Cool.
Where are you in the world right now?
Where this thing? Huh?
Where are you in the world?
Paris.
You're in Paris?
I am.
Nice. I'm in New York.
Oh, nice.
Yeah, we're here for
Where's
the
our
Mount
lovely,
Sinai.
where's our fearless leader?
She is running an ad board right now.
Where at?
The Langham Hotel in New York City.
Langham. Where's that?
Midtown.
Okay. The CVFIL thing? Or no, she works survey, one of the survey things.
Yeah. Yep. So, Nico, can you give me mouse control just so I can go through the first few slides? My goodness, what time is it in Paris right now?
About 1 o'clock, but I'm still very jet lagged, so it's really 7 p.m. as far as I'm concerned. I just got here yesterday. I'm leaving tomorrow.
That's a quick turnaround.
Quick, yeah, it was with the French
Is it
Academy.
working, the mouse?
All right, let me see. Yes.
Okay.
Perfect. Now, Dr. Hugier, usually the way we do this, like we've done it with me before, I'll do the intro slides because this one I can do the intro slides. So I'll do the opening. I will do the thank you to our supporter. I will also do the housekeeping, just reminding everybody that the Q&A. And did you get my email with the Q&A questions?
Yep. These
Great.
are
And I
very
sent them to
specific questions. There's no way anybody is not gonna find out they're planted, by the way. But it's okay with me. I mean, they are very, very specific questions. If I didn't know any better, I think UCB sent us the exact questions that you must ask. Hey, April, how are you?
Hi, Dr. Armstrong.
Can't hear you.
Good. How
Here
are
we
you?
go.
So then, Dr. Hugier, when we get to this slide, I'll pass the floor over to you, but I can
Yep.
still move the slides for you unless you want to control these slides.
Je sais pas, I don't know, whatever you want to do.
So these are the, let's see. These are the IDEF slides.
I thought Leon was gonna take his picture off of that slide. He changed his mind.
Well, and then when we get to this slide, Dr. Armstrong, this is when you'll take control. Nico, can you give Dr. Armstrong mouse control and let her test the mouse, please?
Am I introducing her, Ashley, or are you introducing Dr. Armstrong?
At this point, you will be passing the floor over to her, but I will have
I am.
already read all of her credentials, so you do not have
You
to
would have already.
formally
That's
read.
right. That's right.
Yeah.
So I'll just say, the illustrious, famous, amazing Dr. Armstrong, take over.
Thank you.
All right.
It's
All right,
got
so let's see, Dr. Armstrong, if you want to try to click on the screen, you should be able to move the slides.
let's see here. Oh, it's
That is you moving them.
So Ashley,
what are the okay, got it.
You should be able to use your arrows on your keypad
Yeah.
if that's
Okay.
easiest for you.
Okay, that sounds good. Yep.
Ashley, I'm gonna take over my slides when it's my turn.
Okay, so Nico, can you give Dr. Hugier control of the slides as well then? Nico has the slides up today since I am on hotel internet here, so.
Well, then I have no fear.
Got the fastest internet in the West,
Uh-huh.
or the East. All right, so make sure our phones are silenced so that they don't ping when we are speaking. If we have anything on our computers that would cause notifications, like if email applications are open or anything like that, you might want to close those down so that those notification sounds aren't happening in the background, anything that might distract you when you're speaking. And we should be set to begin unless we have any other notes to talk about.
I just want to test my audio. I just put it on my Yeti.
Sure.
I take my picture out, right? Dr. Armstrong and myself out, the camera off initially.
When we begin, yes, you'll both turn your cameras off.
All right. There goes that. And I'm about to mute myself, so let me know if you need anything.
Okay.
I'll mute myself too, but don't mute me because last time someone muted me.
Oh yeah,
and
no,
couldn't
I
unmute.
you couldn't
Yeah,
unmute.
okay.
No problem. I will not force mute anyone. All right, then we will go ahead and begin. Let me make sure I'm on. And Nico, you can hear me?
Yes, I can hear you.
Okay. All right, here we go. Good evening, everyone, and thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and the title of tonight's program is Transformative Treatment Results in Plaque Psoriasis and Psoriatic Arthritis with the first and only approved IL-17A and IL-17F inhibitor. As moderator this evening, we have Dr. Firas George Hugier, Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, and President of Southeast Dermatology Specialist, and Research Director, Southeast Research Specialists. As speaker this evening, we have Dr. April Armstrong, Professor and Chief of Dermatology, UCLA Health, Professor of Dermatology, Associate Dean for Clinical Research, and Director of Clinical Research Support, Southern California Clinical and Translational Science Institute. We would like to thank our supporter this evening, UCB, for making this educational event possible. Before we begin, a few logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. At the end of the webinar, a survey will pop up in your browser and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill out this survey. Also, within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. At the end of the program, Dr. Armstrong and Dr. Hugier will go through some Q&A questions. Please submit your questions in the question pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Hugier.
Good evening, everybody. Thank you so much for being here with us. Tonight is a treat. Listening to Dr. Armstrong is always a treat, and we always learn great things from her. This program is brought to us by the International Dermatology Education Foundation. The IDEF is a nonprofit organization whose principal mission is to raise awareness and improve dermatologic care all over the world through education, especially in underserved areas. Here we go. Previous educational sessions included the ones you see here today, including the treatment approach of vitiligo, topical corticosteroid application educations, the possible treatments and use of Lumit, as well as many others. And if you would like to stay up to date with the IDEF educational series webinars, please follow the IDEF in all the social media applications, Instagram, LinkedIn, or Facebook, or visit the idefeducationalseries.com to register for upcoming educational events. Without further ado, I'd like to give Dr. April Armstrong the screen so she can start with her session today.
Great. Thank you very much for that extremely kind introduction. And hello, everyone. Thank you for sharing part of your evening with me tonight. I think that, when we're thinking about the landscape for psoriasis and psoriatic arthritis, it has changed tremendously, I think, for all of us practitioners who've been in the area for a while. So it's very exciting to really think about our treatment these days and the transformative results that we can get from our biologic therapies. And with that, I'm going to continue with the slide. If I can have the slide control. Great. So this is a promotional program that's sponsored by UCB, and we're going to talk about the first and only approved IL-17A and IL-17F inhibitor for the treatment of psoriasis and psoriatic arthritis. And I have been compensated for the presentation of this educational information. When we think about our landscape of psoriasis treatment, and specifically thinking about the use of IL-17 inhibitors, and here we're talking about a IL-17 inhibitor that inhibits both IL-17A as well as IL-17F, and specifically thinking about BIMZELX. Now, I know that the audience for this for IDEF is international, so I think that many of you may or may not have had experience with the medication. BIMZELX has been approved in many countries now around the world. And as you can see here, over 70,000 patients have been treated with BIMZELX worldwide. Importantly, when we're thinking about the various indications in clinical trials, it has been studied not only just in psoriasis and psoriatic arthritis, which we will talk about tonight, but also has been studied in a number of other disease areas, and specifically hidradenitis suppurativa as well. For tonight's presentation, it will be focused mainly on psoriasis and psoriatic arthritis. And when we think about BIMZELX, and think about the different indications that we have for BIMZELX. And now we have 5 different indications for BIMZELX. And very importantly, along with that, we have just gathering more and more accumulating information regarding its safety in our patient population. But before we dive into any of the clinical studies data, let's first take a look at the mechanism action with regards to psoriasis. And thinking about the MOA of BIMZELX really in the context of the pathogenesis of psoriasis. Now, what you see on this diagram in front of you is how IL-17A and IL-17F can be expressed in psoriasis patients. And this is seen not only in the tissue, but also in the blood in our patients with psoriasis. If we go from left, starting from the very beginning of the story, we have our dendritic cells, and upon an IL-23 dependent pathway, the dendritic cells can then stimulate naive T cells to differentiate into the green cells in the middle, which is the Th17 cells. Now, the Th17 cells can then secrete a number of different cytokines. And principally important for that, for psoriasis, is IL-17A and IL-17F. Now, it's important to know that the pathway I just described is more considered of IL-23 dependent pathway, where IL-23 is initiator, and then following that, you have downstream elaboration of the IL-17A and F. However, there's also an IL-23 independent pathway, meaning that there are a number of other cell types where it can directly secrete IL-17A and F or have an impact on other immune cells for the secretion of IL-17A and F. And these other immune cells are, their actions are independent of IL-17, independent of IL-23. And they include, for example, the ILC3 innate cells, the gamma delta T cells, NK cells, and so forth. So when we think about IL-17 production, and when we think about IL-17A production, when we think about IL-17F production, it's really important to recognize that the source of the elevated IL-17A and F can be from either IL-23 dependent or IL-23 independent pathways. And if we continue on and take a look at the downstream action of our IL-17A and F, one thing to note is that our IL-17s, they exist as dimers in nature. So when we're looking at them and then their existence, they can be either make IL-17AA homodimer, or they can do IL-17AF heterodimer or FF homodimer. So they make these dimers, and then what they do is that they then bind to IL-17 receptor. Upon binding to the IL-17 receptors, what we see is downstream increased inflammation as well as skin thickening and perpetuation of this inflammatory pathway. So you may ask, I've heard now quite a bit about IL-17A, and what does IL-17F add? So when we look at the translational data, what we noted is that the levels of IL-17F can actually be much greater than IL-17A when we look at the psoriasis tissue. And also, when we look at the synovium in patients with psoriatic arthritis, we also see tremendously elevated levels of IL-17F at much greater magnitudes than IL-17A. So seeing that is an indication of IL-17F playing an important role, a role probably previously less appreciated than we do now with the advent of BIMZELX in our psoriatic disease for both psoriasis as well as psoriatic arthritis. So when we think about the mechanism action of BIMZELX, which is depicted in the next slide, what you see is that on the left lower hand corner of the slide, what we see is a few things. We are seeing these Y-shaped molecules, so those represent the monoclonal antibodies of BIMZELX. And as you can see, they can bind either AA homodimer, AF heterodimer, or FF homodimer. And you may ask, how is it that one monoclonal antibody can bind to both A and F? Well, A and F are kind of like sisters or brothers. They share 50% homology. And the way in which the IL-17 A and F inhibitor, BIMZELX, does its mechanism action is that it binds to the part of the sequence that's shared by IL-17 A and F. Therefore, you can have a single monoclonal antibody, but it's able to bind to any combinations of AA, AF, or FF. Okay, so with that in mind, and knowing that BIMZELX can affect both IL-17, all these different combinations of cytokines, but importantly can inhibit both the IL-23 dependent as well as IL-23 independent productions of IL-17, let's take a look into the clinical data. So now I'm going to first show you the clinical data in psoriasis, and later on I'm going to show you the clinical data for BIMZELX in psoriatic arthritis. And in psoriasis, you will see that the data will provide a great overview with regards to the rapid and complete as well as maintenance of skin clearance in our patients with psoriasis. So there have been a few head-to-head studies in BIMZELX programs. So of course, in addition to the BIMZELX versus placebo study, it's also being studied in a head-to-head fashion against ustekinumab, against adalimumab, as well as against secukinumab. Now I'm going to highlight one of the key clinical trials, and that is the clinical study that's a head-to-head against secukinumab. This is called the BRADIANT study. It's very unique in its study design in that it is the first IL-17 inhibitor versus IL-17 inhibitor study. And it is a IL-17A inhibitor, secukinumab, versus IL-17AF inhibitor, bimekizumab in this case. So let's take a look at the results. So in this head-to-head study, the primary endpoint is at week 16. And what you will see is that at week 16, you'll see 4 lines on the graph currently. And what you will note is that the bimekizumab lines are the teal colored or the green lines, and the secukinumab is represented by the light pink lines. And what you see is that you have both PASI 90 as well as PASI 100. For both of those endpoints, and especially for PASI 100, what you'll see is that 62% of patients, so every 6 out of 10 patients on BIMZELX by 4 months will have achieved complete clearance as measured here by PASI 100, and that is superior to what we see in the secukinumab group. And also for PASI 90, you see numerically greater response rate in those patients in the BIMZELX group than the secukinumab group. So I think there can be a number of different explanations for this, one of which may be that the additional inhibition of IL-17F could potentially be at play when we're looking at this data showing superiority of BIMZELX, especially in the PASI 100 outcome compared to secukinumab. So let's continuing on and then take a look at the additional endpoints here. And you may say, well, that's the week 16 data. Can we look further and take a look into 1-year data? How does that look in this head-to-head comparison? So what you see on the screen right now is that you do see the 1-year data showing that the superiority of BIMZELX versus secukinumab continue to hold over time. So again, BIMZELX are the green color lines, and then the secukinumab are the pink color lines. And as you can see, whether it's PASI 90 that we're talking about or PASI 100, we have greater proportion of patients on BIMZELX achieving those endpoints. And so when you have a patient, for example, who is wondering how they will do with BIMZELX later on, and what you will see is that about 2/3 of the patients on BIMZELX will be completely clear, not only at week 16, but that response is maintained through 1 year. In this particular head-to-head study, there are longer-term clearance data, which I'll show you a little bit later, but the head-to-head part for this particular study ends at 1 year period of time. And then so you have a definitive answer when someone is wondering which one is superior in terms of performance. Is it secukinumab or is it BIMZELX? And in this case, you will have the answer that's here with superiority of BIMZELX over secukinumab. Okay, so let's take a look at things that are beyond the clinical trial results and look at photos that are really captured in the real world and that are collected. So these are photos, for example, from patients living in Florida. And what you see is that in these photos, you have patients starting with BIMZELX at week 0. On the left-hand side, you can see patients with severe psoriasis involvement on the dorsum of the hand and the forearms. And by week 3, well, you already see a significant improvement there with regards to the clearance of a dramatic improvement of the hands. And then on the right-hand side, what you see is a different patient here. We're looking at the scalp. And what you noted is that the scalp, not only significant improvement with regards to the decreasing scaling, decreasing erythema and induration, but also regrowth in hair as well. Okay, now we talked about in terms of this patient that you saw earlier. Let's take a look at some additional clinical images of other patients. So here is patients from the real world, not clinical trial patients, from Virginia and from South Carolina. Also similarly, what you see is that significant improvement after just the first few weeks of treatment. The patient on the left-hand side, you see a fair amount of hyperpigmentation in this particular patient. And this is not uncommon to see in many of our patients when the intense inflammatory process has quieted down. Oftentimes we do see post-inflammatory hyperpigmentation. And this actually can be quite a problem, especially for our patients with skin of color, where this can be especially more pronounced issue for those patients. Okay, here, let's take a look at more images. Again, you see the significant reduction in the erythema, in the scaling, and the persistence of the post-inflammatory hyperpigmentation. But again, the key elements of markers of disease decrease over time. Okay, and then what you see here also on the right-hand side is a patient who has palmar plantar psoriasis, but the hyperkeratotic type, and in a patient with skin of color. So in these patients, we oftentimes have to look a lot harder to make sure that we appreciate the underlying inflammation, because in them, the inflammation may not appear as what we classically think about in terms of a redness that we think about. Sometimes it can even look like it's hyperpigmentation. Sometimes it could look like a more of a violaceous color. Okay. Now let's go on to take a look at long-term clearance. And specifically, we're going to take a look at the efficacy of BIMZELX up to 5 years. Now, I oftentimes think that 5 years is a significant mile marker for a medication. And BIMZELX, its approval in the US actually has post-dated its approval in parts of other parts of the world, such as Europe. But I think we're fortunate that when we launched, we actually had, in the United States, we actually had a number of years already of post-launch data and have the long-term clearance data to discuss. Okay, so let's take a look at up to 5 years of data. So first, you may be wondering, where are these patients coming from? So after the parent study, these patients can enter an open label extension study. And depending really on their response in the parent study, if they did achieve PASI 90, for example, then they can go to BIMZELX every 8-week dosing. If they did not achieve PASI 90, then they can go to every 4-week dosing. So we'll keep that in mind as we take a look at the data. Okay, so let's go to the next slide here. And what we see here are patients, for example, who have gone who started with a Q4 week and then switched to Q8 week. And the reason why we're presenting this data, because for the majority of our patients, if they weigh less than 120 kilograms, they will get the Q4 and then the Q8 week dosing. So this is very representative of what we actually will see in our clinical practice world if the patients were a responder in the first place. So let's take a look at this data. So what you see is that longer term, so this one, when we're taking a look, it's about around 4 years of data. What we see is that about almost 3/4 of the patients will maintain PASI 100 through year 4. So this is important because if your patient had responded well, the likelihood of them continue to respond well is extremely high. So, and then when we look at further on, for example, this is up to 5-year data. And then what we see is that continued response, right? Here we have over 3/4 of the patients maintaining complete clearance for about up to 5 years. So this is quite notable, and this is from the open label extension study. I think when I think about BIMZELX and its approval in the United States and its use among our colleagues, I think overall we can see the dramatic improvement in many of our patients, and especially early on. And we are using this in both patients who have been biologic naive as well as patients who have experienced biologics, and then seeing its efficacy in a variety of different patients with a variety of different history and also a severity ranging from moderate to the very severe. Now, one of the things that we oftentimes think about in our patients who have psoriasis is psoriatic arthritis. We know that from epidemiologic data, about 1/3 of them will develop psoriatic arthritis if untreated. And BIMZELX being studied not only in psoriasis, but also has approval, as many of us know, in psoriatic arthritis as well. So when we're thinking about our patients and the psoriatic disease overall, having a medication that can address both of those and also address both of those with such depth, inciting such depth of response in our patients, it's really important. Okay, so one of the things that I hope some of you may appreciate is that BIMZELX clinical trials in psoriatic arthritis is a little bit different from other clinical trials in that it is bold enough to set a primary endpoint at ACR 50 and at week 16. So there are few things that are really special about sort of the determination of the primary endpoint. And I get really excited in terms of thinking about primary endpoint, think about secondary endpoint, but for a clinical trial, and then this is the first biologic to really measure ACR 50 and at week 16 is actually quite groundbreaking. Why? Because up till now, most psoriatic arthritis studies with systemic medications have looked at ACR 20, so at least only 20% improvement versus now ACR 50% improvement in BIMZELX clinical studies. And then oftentimes with ACR 20, the primary endpoint is usually assessed at week 24, 6 months later. So here you're looking at ACR 50 and at week 16. So quite a bold move when I think about setting this as a primary endpoint. Now, you may say that sounds interesting, but why does it matter to the clinical trial? Well, it matters because your primary endpoint determines a lot of different things, determines how many patients you're going to recruit to the clinical study. It determines also a lot of the internal validity of the study, but it also determines if you're able to assess your secondary endpoints as well. Okay, so let's take a look at this. Again, the first biologic, I would say to be bold enough to use ACR 50, so the proportion of patients achieving at least 50% improvement in their psoriatic arthritis signs and symptoms by week 16, so by 4 months of time. So let's take a look at the data. And I keep saying by week 16 because many times prior to this, you probably saw primary endpoint data for our prior systemic medications. Typically, those are the time points by week 24. And then what we know is that if you do wait a little bit longer, the numbers are going to look better. But this one is at week 16 actually, and it's looking at ACR 50. Okay. I hope you share my enthusiasm for some of the elements of the study design, and took away a little bit about why this trial design is actually the endpoint is different and is bold. Okay, so what we saw in the clinical study is that for psoriatic arthritis, there were 2 trials that were done. One trial looked at the bio-naive patient. So that's the clinical result on the left-hand side. So these are patients with PSA who haven't been on a biologic before. And this is called the BIOptimal study. And what they found is that about 44% of the patients on BIMZELX achieved ACR 50 compared to 10% in the placebo group. So achievement of ACR 50 and then 44% by week 16 is very notable, and then really places this particular IL-17 inhibitor at a place where when we think about highly effective medications for PSA, I think the BIMZELX data really speak to that. Now let's take a look at the outcome on the right-hand side. So the graph on the right-hand side is in patients who have had TNF. They're either intolerant to TNF or they have not responded optimally to TNF inhibitors. And then in this study, that study is called the B-Complete study. So in that study, what we saw is actually very similar results than what we saw in terms of the biologic naive trial. So for ACR 50, we see that about 43% of the patients who are TNF-IR patients, so incomplete responders or intolerant of TNF prior, now when they are tested on BIMZELX in the clinical trial setting, about 43% of them would achieve ACR 50 compared to 7% in the placebo group. Okay, so this is notable, and this is really important. Now, if you're someone who said, well, what about ACR 20? Because that's what I'm used to. Well, you see that on the right-hand side, about 60% of them achieved ACR 20. So you do have somewhat of a point of comparison. But when I think about that, ACR 20 is a much lower bar. And when you have a much lower bar, it's actually really hard to compare, in the future among the different medications. So when we're using higher and higher bars like ACR 50, ACR 70, for example, you're able to see the distinction, for example, among the various medications. Okay, now let's continue on and take a look at the longer term data. So here we have can these people that I showed you that have achieved ACR 50 by week 16, and let's take a look at the clinical trial results, not only through week 16, but now over a 2-year period of time. So those poor unfortunate folks that were initially randomized to the placebo arm, after week 16, they can get BIMZELX. And what you see is that over time, whether it's through the end of the first year or during the open label extension into the second year, what you see is that specifically, you see the maintenance of this good response. And essentially, at 2 years, what you see is about 50% of the patients on BIMZELX will maintain what we see ACR 50 at 2 years. So this is, again, quite notable. Now, what about BIOptimal? So here we're looking at the BIOptimal trial and looking at our biologic naive patients, just as a reminder. And here are patients who haven't had BIMZELX or any other biologics prior to the clinical trial, were then randomized into getting BIMZELX or placebo. So what we see here is that ACR 20 around 64%, ACR 50 over 50%, so 52%, and ACR 70 at 40%. So I pay a lot of attention to the higher endpoints such as ACR 50 and ACR 70. Again, because they are they're harder to achieve and therefore a bit more distinguishing. And then what we see, actually, you will notice this looks very similar to earlier time points. So they're able to maintain at 2 year what they were able to achieve at 1 year. So again, 50% achieving ACR 50, and then about 40% of the patients achieving ACR 70. Okay. So we talked about ACR data, but there are other manifestations or domains, as we like to call it, or as the PSA-ologists like to call it, that's affected in psoriatic arthritis. And what is additionally shown is that 77% of the patients experience no radiographic progression. And then in terms of the achievement of achieved resolution of dactylitis, 76% of patients achieve that. And then when we think about enthesitis, so that is inflammation of the tendon insertion points. And then typically it is the Achilles tendon that could be affected. The fascial sheet in the plantar surface can be affected as well. So in those with some baseline enthesitis, you see that 50% of them will achieve complete resolution of enthesitis with that. And then you have swollen joints, up to 50% experience no swollen joints during the first 16 weeks. And also in terms of the nail resolution, we also look at up to 46% of the patients across the different trials have attained that at week 16. All right, now we talked about the efficacy for BIMZELX, for psoriasis, and then also for psoriatic arthritis. And now we're going to talk a little bit about the safety profile for BIMZELX. And the safety profile that we've accumulated over time now we have up to 5 years of safety profile for BIMZELX. So this is really exciting because when we look at the safety data, it's really important to note the length of safety follow-up. And the reason I say that is because when we follow patients over time, the longer we follow them, the more we are more confident that things that perhaps signals that we may not see earlier on, they could arise later on. Therefore, longer safety data following a large population can be very informative. But also longer period of safety data that's systematically collected is very informative. Okay, so let's continue on in this regard, and let's talk about the 5-year safety data. So here, what we have is the short-term week 16 safety data. Overall, what you'll notice is that the rates for placebo versus BIMZELX are very comparable. And I'm going to talk a little bit about the oral candidiasis data a little bit later on. You will notice in the BIMZELX package insert that there are no contraindications and no box warnings. And when we are taking a look at the longer term data with regards to safety data for psoriasis as well as psoriatic arthritis, what you'll also note is that the safety profile look, I would say, very similar between these two indications, probably not too surprisingly. And overall, we did not see any new safety signals regarding that. And when we take a look at the further safety information here's the rates of suicidal ideation and behavior that were reported in the BIMZELX clinical trials. One thing to note is that the collection of these events through the CSSRS data form is the most extensive that we've seen in the psoriatic disease program. So patients were asked about their suicidal ideation and behavior every time that they return. And they, as you can see here, in terms of the psoriasis patient population and the psoriatic arthritis patient population. And overall, when we were looking at these numbers, we note that with regards to the clinical trial rates, the rates of suicidal ideation and behavior that were collected with BIMZELX in the clinical trials were very similar to that of clinical trial results from other biologics, as well as overall patient population with psoriasis. So here, what we see is a diagram looking at the events, so exposure adjusted event rates. And what we see is that, for example, the very left side is a suicidal ideation and behavior with BIMZELX, and what you see is it's around 0.13 per 100 patient years. And right next to it is other anti-IL-17As. As you can see here, it's within the realm of where we see the other anti-IL-17As. And then we have a number of other drug classes that's listed that are following, ensuing that. And on the very end, what you see is you have patients with psoriasis, and these are the rates that have been reported in, for example, epidemiologic literature, other clinical trials. But overall, you will notice that the patients with BIMZELX had very similar suicidal ideation and behavior rates compared to the results in the clinical trials for other biologics, as well as those from epidemiologic studies. In addition to that, when they looked at liver function enzymes, and they noted, for example, in the placebo-controlled as well as active controlled clinical trials, that BIMZELX's rate of ALT or AST elevations were very comparable or numerically either the same or actually numerically lower than some of the actively controlled comparison arms. So here, as you can see here, when we look at the forest plot, overall, what they see is that we do not see an increased rates in comparison to whether it's the placebo or when we're looking at the forest plot or in comparison to some of the other established biologics that were used as comparator arms for the BIMZELX clinical trials. Okay, and so let's talk about oral candidiasis. So when we look at patients with oral candidiasis in the psoriasis clinical studies, it's really important to note that the vast majority of these cases were mild to moderate. And when we're looking at the entire clinical trial program, the proportion of patients who actually discontinued BIMZELX due to oral candidiasis is very low. It's about 0.7%. And when we think about that and thinking about our patients that we have prescribed BIMZELX to, when you look at the totality of the data, what we see is that most patients who end up do experience oral candidiasis, they typically only experience one event in the first year. And when you look at the events over time, they actually decrease, incident rates decrease over time. They are quite treatable, oral candidiasis. I prefer to treat them with oral medications, oral fluconazole, for example, because it is very convenient for our patients. So my personal preference, if they don't have any contraindications, is to use oral fluconazole for that. And here are the additional indication and important safety information. We've gone over a number of them already. Just as a reminder, before initiating BIMZELX, you want to check patients for their tuberculosis status and prior to initiating BIMZELX. In addition to that, we want to avoid the use of BIMZELX in those with personal history of inflammatory bowel disease, and as much as we can, ensuring that our patients receive their immunizations before starting BIMZELX. And I'm going to now talk a little bit about dosing. And the dosing that I'm going to talk about here really is pertinent to psoriasis and psoriatic arthritis. But it's really important to note that it does come in two device options, either prefilled syringe or auto injector. Please note that it can come in the 160 milligrams, 1 ml in either of those device options, or the 320 milligrams, the 2 ml option in either of those devices. So whether it's prefilled syringe or auto injector. Now, many of my patients find the auto injector convenient. Some of my patients who want to actually inject themselves, I have the option where they can control the injection rate, then I would use the prefilled syringe for those patients. Okay, so let's review the dosing. I think this will probably be a review for many of you, but it's always good to remind ourselves because sometimes the dosing can be confusing since we have so many different biologics now. So for BIMZELX, for PSO, for psoriasis, if your patients weigh less than 120 kilos, then you want to do 320 milligrams every 4 weeks for the first 16 weeks. After that, the maintenance dose will be 1 dose of 320 milligrams every 8 weeks thereafter. So when you think about this, this is really after the induction period is 6 maintenance doses per year. Now, if you have someone who does weigh over 120 kilograms, then you want to do every 4-week dosing for those patients. And then underneath, you see PSA dosing. So psoriatic arthritis dosing is different from psoriasis dosing. And if you have a patient who have psoriatic arthritis, but they don't have moderate to severe psoriasis, let's say they had just mild psoriasis, then you still want to follow the PSA dosing, and that would be 160 milligrams every 4 weeks. Now, you may say, what if I have a patient with psoriatic arthritis and they also have moderate to severe psoriasis, for example, and then you want to follow the psoriasis dosing, and so that's really important. So if you have someone who have active PSA and coexisting moderate to severe psoriasis dosing, then you want to use the moderate to severe psoriasis dosing. And if and then just as a reminder for everyone that I know it's not included in this particular deck, but BIMZELX is also approved for moderate to severe HS. And the dosing for that is 320 milligrams every 2 weeks for the first 16 weeks, and then every 4 weeks thereafter. And the way I think about it, it's essentially double the frequency as what we typically use for psoriasis dosing. Okay. And so when we think about this, it's so important that we have good access to the medication. So there is a very robust access program. It's now 90% commercially covered. Insurance patients can access BIMZELX. And there's also the CVS Caremark exclusive plan in place for patients. And it's very important to also know that there are the BIMZELX Navigate Bridge program for patients who may need access to BIMZELX while their insurance is pending. So if you have any questions, please note that the manufacturer have dedicated nurse navigators who can help eligible patients throughout their treatment journey. And also there are field access specialists who can help answer your questions regarding your specific patients to ensure that they get access to that. Okay, so this evening we've gone over the results for BIMZELX in our patients with psoriasis. We talked about short-term placebo control period. We also talked about sustainability of that good response longer term. We looked at bio-naive as well as bio-experienced patients with PSA treated with BIMZELX. We also looked at the dosing frequency in addition to the safety data across the different indications as well. So with that, I hope that you're able to transform your patients' lives really with this medication, and I hope that you will be able to also find good results in your patients. And this is, in case you wanted to share your success story, this is a QR code that you can scan to share your success story. So with that, I'm going to, I think now engage in a fun dialogue with Faraz, right? And we're gonna talk about some of our audience response questions. So please feel free to ask any questions.
Wonderful, wonderful presentation, Dr. Armstrong. You never disappoint in your presentations and in the explanations. So thank you so much. I know personally enjoyed it, and I know our audience has as well. There are a few questions that came out. One is, how do you efficiently assess joint involvement with your PSO patients?
Yeah, that's a great question. So for me, I would say, Dr. Hujair, oftentimes first through asking very simple questions, because we're all very busy in our clinic. But I always make a point to always ask them about their joints. And then I ask that when they get up in the morning, do they feel stiffness in their joints or in the back? And if they say yes to that, then I say, well, how long does the stiffness last? And the reason for that is because we know that PSA is an inflammatory arthritis. So with prolonged periods of rest, that's when they get uncomfortable. And then if they do have prolonged periods after, if they say, well, yeah, I have stiffness, I just feel stiff everywhere, and it takes me maybe a bit of time to get out of bed and before my joints feel normal, then I say, how long does it take you to really kind of this ungel effect, how long does it take you to do that? So that's the main question that I ask. And but if they don't have any stiffness when they wake up in the morning, then it's less likely that they're going to have an inflammatory arthritis. So if you were to ask one question, and I've talked to many rheumatologists in my life, that's probably the most high yield question. And then if they say yes to that, then you can ask about tender swollen joints. But typically they would have stiffness in their joints before they experience a swelling, for example, in their joints.
I think in my experience, I feel the same way. It's a really, really good question. I think the question I find out that I should not ask are the questions such as, do you have joint pain? The answer often is no, because they're not really looking for the stiffness, and many of them think that's a normal thing as you age, they're 30 or 40 years old. So asking about stiffness in the morning, I find is the most helpful in raising our suspicion for psoriatic arthritis. Completely agree with you. Another question is coming through, and it is relating to the suicidal ideation behavior. Warning, how do you deal with that when it comes to your patient's mental health challenges? How do you discuss that with your patient? Is it something that is an important part of your discussion?
Yeah, that's a great question. So one of the things is that it's something, if my patients ask me about something about it in the label, then I would say that this medication is studied more intensively in terms of mental health than any other prior biologics. And there were patients who experienced some suicidal ideation and also exhibited suicidal behavior. However, the rates of that, when you look at that compared to the general psoriasis population, it is very similar. So, and then also we note that with the treatment, patients, actually their scores with regards to their quality of life have all improved tremendously. So if they're experiencing thoughts of suicide or notice that the depression worsened, I want to make sure that they talk to me about it, and then as well as their primary care physician, so that I am aware of that, and then we can think about the next steps. However, I do emphasize that now that we have longer term safety data for BIMZELX, and then looking at those safety data year by year, what we see is that the rates of patients on BIMZELX, their suicidal ideation and behavior are first of all, there's no increased signal in that over time, and then it's still consistent with the overall psoriasis patient population, regardless of therapy.
And again, our audience, I'd like to note that the suicidal ideation behavior in the label warning is very specific to the United States. Actually, the bimekizumab has been approved way before it was in the United States. This is a non-issue and not present. So it is something that we deal with more in the US than anywhere else. Another question I think is interesting. We're talking about the new National Psoriasis Foundation paper on on-label remission. Can you say what you think of it, or what your points that you take out of this article, and does it influence your approach on how to make a decision about how to treat a psoriasis patient with biologics?
Yeah, so to your point, this is a very hot topic right now, Dr. Hujir, is the thought of remission, because our patients want to know if their disease is in remission. And what we have as National Psoriasis Foundation, and I was part of this effort, is looking at defining remission, and specifically because we actually do have a definition already that was established on off-treatment remission that was published a few years back. And based on the way the medicine field is going in, for example, in lupus and RA, there are what's called the on-therapy remission, meaning that are you able to get on an efficacious enough therapy such that you do not, for example, experience any visible signs or of the disease, such that the disease itself is in remission in all the sense of the word, but you're still on therapy for it. So the definition by the NPF for this on treatment remission is defined as anyone achieving complete clearance of skin, so BSA of 0% or IGA of 0, which is clear, for at least 6 months. So to qualify for this remission, they have to be completely clear for at least 6 months. So if they are longer than that, they definitely still qualify for the definition. And what does it mean, and what, how does it correlate to the different other endpoints? And then I think we're very excited to see how that may correlate. Our discussions have been in creating this definition through a Delphi process and through a patient interview process. Also, patients had a lot of input into that. Is that likely when your skin is completely clear, it's intimately associated with people's improvement in their quality of life, likely, and also significant improvement in their symptoms. But why that's meaningful is I think now we have a really high bar to look at how our therapies may measure up to this definition. And it's something that the definition can be very easily, I would say, operationalized, not only in the real world, but also in the clinical trials. And having that bar, which is set extremely high, I would say, and I think it will be very interesting to see which one of our biologics or oral therapies can, and what proportion of patients may be able to achieve this on-treatment remission.
Do you believe that early treatment as a follow-up, as early treatment gives a better chance at remission by this definition?
I personally believe that with the data that we have. I think for a number of different reasons, patients who would qualify for the medication in the first place, if they're treated early, you will see that time after time, the results have shown that those who are treated earlier in their disease course and able to get their disease under manageable conditions, they respond better than patients who wait around and then treat their disease. So two people can come to us with the exact same body surface area involvement, and if one person only had their psoriasis, for about 6 months, and the other had a psoriasis for 6 years, there's going to be a difference actually in how their response will be to the therapies, depending on when we start the treatment. So there can be a bit of maybe disease modification with earlier treatment.
It's amazing. It's very interesting. We are so far from the early days of biologics and psoriasis. I think the options are really good, and we have really good options for our patients to treat. Dr. Armstrong, thank you so much for being with us tonight. Thank you for all our attendees for being with us and listening to this excellent presentation. I am sure that you have gotten quite a bit of information and learning from it. With this, we would like to end the session, and thank you again, Dr. Armstrong, for being here.
Yeah, thank you, everyone. Have a great night.
Thank you also for our supporter, UCB, for making this available and possible for us. Have a good night.